Vasquez. Today we have a really amazing guest from far away. He finished his day already. He's in Singapore at the moment. So I say, I slept your entire day. How a shame is that? So we have Wen Cheu. He's a great friend of Hamid and us. We have similar trainer. We went to different parts together. But the most important is we create a great relationship, and I think we feed each other with the knowledge we have, and that's what we have in here. He has something really amazing to talk. So Hamid, let's say good morning to
Good
everybody.
morning, everyone. Good morning. Today is a great day because our good friend and colleague Yue Weng Cheu has joined us. He was gracious enough to give us his time and part with some of his knowledge. So we do have similar backgrounds and similar thought processes, but in the recent years, Weng Cheu has done a lot of great work in the field, specifically on the tongue and lingual frenectomy, and so he's done. I've watched a couple of his lectures, and I thought that's a big component that we need to add to our series. So I'm really excited to have him here and give a little taste of what we have seen from him in this 1 hour. Good to have you, Weng Cheu.
Good morning. Thank you, Hamid. Thank you, Javier. Thank you for having me. And it's such a great opportunity to meet up again. Yes, we were classmates, and you are all my teachers too. Yeah, so I have an opportunity to visit both your practices and closely work with you in some of the cases. And I learned a lot from both of you. So yeah, I think we have common foundation, and this is opportunity for us to explore a little bit here and there that others have not gone before. And now I'm just going to help to bring some of this information to share with all of you so that we can, like I say, have a bigger picture of what the whole body is all about. So for my own interests, yes, I think it all started with my own problem. Yeah, I had tongue tie, right?
So okay, let me first introduce that.
Yeah.
Hold on a second.
Okay.
Before we get into the juicy part. For many years, we never give or some people recognize, but other people doesn't recognize the power of the tongue. And most people think that the tongue is only made it to blame people or to gossip. And this is just the funny part. But the power of the tongue is amazing during all the phases of growth and development. We come back to embryology, and when we see how is this process of the development and what it happens during the process of breastfeeding, and what is this function in that seal to the nipple to be able to start activating the occlusion and breathing is part of the initial part of the process. Then we have this little kid.
Can we stop here? We're getting some feedback that some people on Facebook are not getting the sound again.
Okay, we're trying to.
Alfredo, can you check that for us? Instagram is okay, apparently. Yeah, Facebook, no sound. They cannot hear Weng Cheu.
They cannot hear Weng Cheu.
Okay.
They cannot watch. You can hear the sound? No. Okay. Yeah, we're checking. I apologize.
No worries.
Okay.
No, empieza desde, si continuemos, ¿está ahora funcionando? Ok, so seguimos. Okay, we continue. We fix it, but we don't gonna cut it so we don't lose the track of the video again.
Okay.
So then we were talking and we were saying that the tongue has a specific functions besides the jokes I say. But technically, the tongue plays an important role from the stage of breastfeeding, and then when that kid start growing, we start working in the process of activation of the face and all the structures get developed into the kid by function, and you will see with the orthopedics that we have invited. But then the tongue continue being important part of the system. And it's really important that we understand that it's not just an organ that of course has multiple muscles involved that can create different kind of dysfunction, pathologies, or just the reaction of the tongue itself in the functional that we have, like phonetics or chewing cycles, that has a specific pattern. But not being enough, we have patients that they more sensitive than other ones. And then when we start getting deep in physiology, we start involving another diagnostics into the patient to get to see if the patient has a tongue tie, a frenum. And over years has been different concepts, mostly in orthopedics, that they try to treat the kids with phreniectomies. But in the time that lasers start coming in, people start doing more simpler phreniectomies that apparently the frenum was free, but we wasn't cutting the aponeurotic tissue. We wasn't going deep enough to be able to release the fascias. And the fascias is all this tissue internally that connect from the dura madre all the way down to the feet, and all these structures get involved. So Dr. Weng Cheu, with this knowledge of physiological occlusion, that we cannot try to see with all the factors that affect or influence the system, he found his niche to say, okay, I'm going to check this population and I'm going to do research extremely in what is this functionality of the tongue and how this pathologic tongue tie is going to affect the physiology of these patients that I've been treating, but in many times I don't have good resolution. So now when come up and now educate us about this, because I'm really excited to learn from you.
Yeah, like say, the best way to learn is to help yourself, right? To solve your own problem. So I had, breastfeeding issue. My mom can't breastfeed me, so she blamed it on the soup that she drank, and she has no milk. But actually, it's not her fault; it's mine. But the truth is, right? Not being able to suckle, the tongue tie for my case, right, created this whole situation of breastfeeding issue. Later on, I grind my teeth a lot when I was a young child, all the way to adulthood. Um, People don't like to share the tent with me during camping because I make a lot of noise. When I was serving the army in Singapore, right, I was identified as the rat because I make kind of sound every night. And
Wow.
and later on, right, at just the age of 30, 31, right, I have such bad pain on my left side, neck and hip. So I limp a lot sometimes, and I need furniture to get up. So, like, look what's going on now. I just finished my dental school. Yes, I play a lot of soccer, and we thought it's a combination of work and injury, but it is really not the case. And that's when, of course, my earlier mentor, Dr. Jerry Lim, Dr. Ronnie Yap, they were trained under Clayton. So I went over to Occlusion Connection and found out about neuromuscular dentistry. And the surprising thing for me is this, right? When I was there, still suffering some pain, I got my bite taken, right? And just from the bite itself, I'm able to feel the difference in my body changing. And the pain that used to last for 1 or 2 days on my left side will go away almost like in 15 minutes. Yeah. So that tells me there is something that goes on with the whole body trying to level up so that there won't be impingement at the bottom part. So we always talk about ascending, descending kind of influences. But to me, it's never so clear cut. It's always top to bottom, bottom to top all the time. And with this understanding of that, yeah, I have deficient bites because my low tongue posture, right? Then I have a deep bite. with my deep bite, right, obviously I have a slightly more forward head posture. So yeah, I don't have a nice lordotic neck. I have a straight neck, right? And with that, right, yeah, problems still persist until I started to understand, or should I say, I asked myself the question: why do I end up with this posterior insufficiency, right? Why am I not supported sufficiently at the back? What is missing? So thinking about it, oh, I guess it's my tongue, right? My tongue didn't do the job to help me support that whole vertical while I'm developing, so that the tongue rests low. For my case, it sits on my teeth, and it's like a big fat block. Yeah, using my back teeth like armrest, and then my teeth starts to intrude and also lingualize,
Yes.
right? And then when I bite, yeah, I get into a more retruded bite position, and that creates a more obstructed airway. Obviously, I need to compensate for it, and a forward head posture open up my airway, and I survive but with pain. So what can I do then, right? And obviously over a certain period, then I get to know more, especially Clayton does teach about James Gary kind of work, and from there also I found out more about myofunctional therapy. And then that's another deep dive into another rabbit hole, right? We all talk about our rabbit holes. And once I'm there, then I start to understand, yes, the tongue actually needs to be up against the roof of the mouth, touching the palate almost all the time. We yes, like we say, with occlusion to us, a lot of us would immediately think about teeth. But the truth is, in the whole day, hardly any biting until we eat. So the
Or
teeth are
swallow.
separate. Or swallow. Yeah. Sometimes even a swallow can be a very light touch only.
Yeah.
So now the thing is that all this separation is not just a random movement. So if we put the tongue down and we let the jaw hang loose, right, then it's like a little boat in the open sea. And this boat is going to float all around. And while the teeth are developing when we are growing, right, it can float to the wrong side, to the front, to the back, and then we have our lateral shift, we have our retrusion, protrusion, and we get our teeth lock us into a not ideal function. But if I can get the rudder, the tongue always like to be in the center, not to left, right, front, or back, just right in the center. When it's right in the center against the palate, lips are closed. So when the lips are closed together, we have a nice anterior posterior referencing, right? Then the tongue goes into the center and it gives us our lateral, right, and vertical. And of course, we still have a yaw and pitch as well that is actually addressed by the tongue positioning. So with that, as I post in my Facebook, right under the thread where when you discuss about this, let's talk about occlusion. We want to talk about tensegrity, right, or tension integrity. So literally with the tongue up against the roof, right, lips closed, and then the whole jaw is now pushed from the back down. So we separate the condylar space, right? Open up the condylar space, should I say, with the tongue guiding into that whole the whole vault correctly and making references for us. So then now we relate our lower jaw correctly to our upper jaw, and lower jaw happen to hinge at our TMJ. Upper jaw, you can move upper jaw, right? So our upper jaw is hinged, COC1 indirectly, right? So when we yawn, open, so 50% upper jaw, lower 50%. So we know we need to get this right before we even start talking about this. Because if my head is tilted, my lower jaw will be this way, right? We're not going to get a correct referencing and we start working on our teeth. It's not going to be too ideal. So I trust the tongue to give us a good reference. But the big BUT is, it's not easy for everyone to have a proper tongue position, right? We all say tongue up, but some will be just to the tip, some is just partly up, some get all the way with the back end of the tongue up, right? So that is most ideal with the suction hole with lip closed. But we need to train. So we put into all this into practice so that we can rehabilitate our patients so that they can create the right environment for themselves. And sometimes this treatment might take a little bit longer. It doesn't mean that it doesn't have short-term improvement, but it's just that we're taking a more long-term view on how this is going to play out. Because, like I say, most of my cases, we are doing orthodontic rehabilitation after we find a bite. Yeah, sometimes this give us a little bit more leeway to adjust to the position again and again and again. As what Peter has mentioned earlier, yes, we work in a whole community of experts. I cannot do everything. So yes, we have a PT, we have our osteopath, we have a chiropractor, we have our craniosacral therapist, so that they can.
Yeah, but don't go to that because that's part of the questions yet. We're gonna go over those questions. So we focus here into share the information to create a foundation about how the tongue tie release can help to improve the patients. It's beautiful to see how you implemented the concepts of Dr. Rocavaro about the law of the 50-50, the exercises and the position of the tongue that has been described for him. Dr. Gary was an amazing, also talking about airway and connecting cervical spine. So I think this multidisciplinary approach is what it makes you to go deeper. Now, since the questions that we have are more generalistic in base in what is going to be the interfaces that you will work, or what is going to be the interdisciplinary team that you work in, and even the sequence that you will do that, why we don't focus a little more in the procedure by itself, or something that the people can have more foundation before we still connected with why? Because there's so many people that at this point is asking me, why you bringing somebody to talk about the tongue if you're talking about occlusion, right? So let's fill out this hold or this platform to show how we will connect it. Now you express what is the neutrality zone of the tongue, but now let's go and see like something that people can do in the house right now, that they can see what is the tongue position for them, that they can see what is kind of the test that you do with the patient. And then maybe we can go deeper in the procedure and the different procedures, because as I mentioned before, is many people that they trying to make the tongue release, but they're not going deeper enough. They don't debride the tissue, and they try to do it with laser because, of course,
or some people are actually going too deep. You know, there are valid techniques that, you know, for instance, I took a course with the Breed Institute and Dr. Zaghi. Tell us a little bit more about your techniques and how you go about it.
Okay, so yeah, I think my influence also very much comes from Zaghi and what he's doing. But for my case, right, I started with doing some for children, some for adults. But I think my biggest realization is for the babies, right? So when I was doing for the babies, it really gave me such a important realization, right? That all this starts from then. I have babies coming in unable to breastfeed, obviously. Some of them suffer regurgitation, swallowing issue, breathing issues, sleep issues, right? They can't be on their back. They have to be carried up. And when they are trying to swallow, right, they can't lift, so they are not able to coordinate between the swallowing and breathing, because we have to choose one, right? And through them, right, I see the very initial, because for a baby, the frenum is still so thin, right, so little, right, and it can be cleared quite quickly with the laser or any other technique that the doctors will apply. But for me, I use the laser. I can clear that up, and we can see immediate improvement. So the baby brought back to the parents, the baby can breastfeed. The mom won't feel any more pain, right? And it has a lot of realization. So I'm asking the question also, then what is going on? Why? But when we look at function, we look at all this structural component, we must always harp back to neurology, right? We all controlled by electricity, and the neurology controls it. So, and when we talk about neurology, I talk about reflexes. So the suck, swallow, breathe reflexes is something that we don't really need to learn, right? It's all innate. The moment we are born, right, I can't see that clearly. I can't move my hands and control them. Even my bowels, I can't. But my tongue, my lips, my face, I have to be in full control, or else I'll be eliminated from this world. So the suck, swallow, breathe reflex is so important, and the tongue is now starting. And Javier mentioned so clearly about it that we start to breastfeed with that control. But the thing is, right, when we do this, right, we has no one take into full consideration how many cranial nerves are actually involved in breastfeeding, right? So if we think about it, then we start to realize all 12 cranial nerves. Meaning, if let's say when the baby feels the nipple, right, the trigeminal nucleus getting from facial trigeminal nerves, and they have a sense, and then it sends signal to the accessory nerve, so that the baby knows how to turn naturally. And the facial, all right, open, latch, tongue, hypoglossal, glossopharyngeal, and then the vagus have to control between your breathing and your swallowing and the whole gut and the heart rate. And of course, the baby can have a smell, scent to target the mom. The areola is, it's not so clear to him, but that's why the nipple is darkened, so they can actually focus to that. And if you put a baby on the tummy, the baby can still crawl all the way until they can breastfeed using the vestibular cochlea. So all 12 cranial nerves is employed to get one thing done: breastfeeding. And if we just don't get breastfeeding to be optimal, we are under training all these nerves, their coordination as we grow up. So that's why then functionally, right, a lot of things starts to get into trouble. But even before we talk about breastfeeding, what is the first thing when we get out of the womb, or after the birth canal? What's the first thing that you will do? Catch your breath. So that first breath is so important. And the fact is, what coordinates it? Again, right? All your cranial nerves, right? So your jaw has to open, trigeminal fire. Your tongue has to also fire. If let's say you really let it go, right? Trigeminal let go, tongue let go, and your accessory let go. I'm totally suffocated, right? So all this, so the primary thing, being highlighted by Stephen Porges, right, polyvagal theory, that really our primary role of all our cranial nerve is just to survive, help you to survive. First thing is to get your breath, or get your cardiopulmonary system to go on first, right? So you catch your breath. So all these systems, everything has to be in a right position, right? Tongue up, all this, so you can breathe. So if you let go of one system, let's say your tongue is down, you're already blocking the airway a little. Then now you have to ask the other nerves to do something. So you have to ask your accessory to do a little bit more. So your accessory have to stick your head out, right? And if it's still not enough, you try a trigeminal to fire, and then all your facial nerve to coordinate. So all that is a compensatory mechanism that we can create when we don't put the right thing right at the first place. That means breastfeeding is not just for the nutrition, not just to get the breast milk. So you just don't pump and store it and say, yeah, then I let it out inside a bottle. The act of breastfeeding activates all these cranial systems, right? And create the growth and development and the coordination that we need for the rest of our life, right? So that is so important. And then later on, as we grow up, just by thinking about chewing, let's say we chew. It's such a simple thing, right? Everything we put something in our mouth, we chew. But then are we thinking about how our system is again coordinating? Our trigeminal nerve, our vagus, so every one of them is again, right, acting to help you to chew well. For example, if your accessory is not working well, Your head is tilting to one side. It's not easy to chew. You have a deviated bite, right? And if let's say your balance system, just imagine a man in space. He's floating around. Asking him to chew is not easy. His whole jaw is moving all around the place. You sit upright, you chew, it's right. So all this cranial nerve again, right, plays such an important role to coordinate this. And when we have one of them or few of them not in position, right, we ask for compensation. So I see in baby, I see one young girl and a elderly man. So this young girl came to me. She has already seen the neurologist, and she's diagnosed to have Tourette syndrome. So she continued to stroke her shoulder, stick her tongue out, blink, shrug, blink. So there's a lot of uncontrolled movement of the face. So I can't be sure I can help her, but all I did ask her dad is, um, like, what is the options given by the neurologist? No options, no surgery, no medication. So 40% of the time she will not better. 60% she will. So that say I'm not going to take a bet on that. It's too high a risk. So coming to us again is because of the video Brian Hill, right, put on YouTube. Yeah, he was treating his Tourette patient. So the patient saw Brian Hill's YouTube thing about neuromuscular dentistry and came to me. All right. So for me, my neuromuscular dentistry is this then for the young one. I say, can you, and obviously she's mouth breathing, tongue is down. I asked her to put her tongue up. She still struck a little, but less. So I did one more thing that made a difference. I asked her to slow down her breathing. And slowing down her breathing is activated strongly on her vagus tone and also her parasympathetic system. So just by putting the tongue up, breathing slowly, she was looking at her mom and she smiled, right? For the first time in many, many years of her life, right? She doesn't shrug, she doesn't stick her tongue, and she was all right. Okay, so what goes on? It's just because that all this jumble information is making her react so that she can just, like I say, continue to breathe. So by putting her on intensive myofunctional therapy, right, 3 months, she came weekly, and of course many other therapy as well. Once she can put her tongue up and control her lips and she breathes through her nose, she's a normal, healthy, adorable girl again. Yeah, 8 years old.
That's
So
a great story.
yeah, it impacts me a lot. It impacts me a lot. And it happens to another 71-year-old man. It's the same thing. He is non-stop moving. And if you look at his arches, right, his 2 lateral incisor is instanding. He has worn down teeth, abfraction all over. He was in the hospital because he went to my friend's hospital in Cambodia, right? I was there consulting for TMD. Because of his first molar, his second molar is lost. First molar is already worn down to the pulp and it's painful. That's why he is asking for extraction. But he went all over the world to solve this problem, not knowing that in his own backyard, accidentally he met someone that happened to do neuromuscular, and I sort of think about cranial nerves. And all I did again is just to ask him, why don't you put your tongue up and let's see where you go from there, right? And the videos we took of him before and after is so amazing. Again, the tongue is up, the face doesn't move, right? The tongue is down, the face will move, and uncontrollably. So that gave me...
I'm sorry, I don't mean to cut you off, but this is a very interesting subject you brought up about the importance of myofunctional therapy or the lack of it in the current dental field. It seems to me like up to 70 years ago, it was standard protocol to have that as part of the dental curriculum, and all of a sudden it kind of disappeared. At least here in the United States. I don't know how it is in Singapore or other countries, but Yeah. So can you elaborate a little bit on that? I mean, I know you're preaching to the choir. I may have the only office in the whole Dade County that actually has a full-time.
Remember that we have a little restriction on time, and now I'm gonna become the bad boy. Still, we have to connect the concept with the rest of the system. Honestly, I'm as fascinated as everybody's gonna be. I have people that say that I don't interrupt him, but still we have some content that we need to develop. So now we know and we understand how important is the tongue. Honestly, we can be talking about this for days.
Well, this has to be on his lecture.
So fascinating. Yes, exactly. So let's say now you develop this protocol. What people can do quick, because I've seen different tongue ties, no? So we have that tongue tie that go to the tip of the tongue and make it like break it in half. What can be a quick way for people that right now get to start visualizing what is tongue tie, what is going to be the little exam? And then let's say how you involve this with the joints and with the occlusion, because even though you say that most of the time we are still having the tongue helping us as an element to keep homeostasis, still is going to be this event where the teeth going to bed together. How do you create this transition between occlusion for the freeway space related with the tongue, creating the balance, all the way to the occlusion, and how is that influence your temporomandibular joints? Just like we kind of keep a little bit of the sketch, then we will go over the questions because we have like 25 minutes.
Okay. The thing is that, right, I think why we don't do it is because it is not in our hands, right? The power to control it is not in our hands. It's in the hands of our patient. We can't do a lot. We can only advise. We are consultants, right? The patient has to take the first step to recognize it and then make the change, right? That's why I think most people don't want to do it, because many dentists are OCD. We want to control to the millimeters, right? So if the patient is not conforming, we are in trouble, because we are still in charge, right? We are responsible for the outcome that we want. So basically, if you look at the tongue, right, we have a maximum opening, right? And you can put your tongue to the tip. You see my maximum opening and my tip up and my suction up. I'm still under. So I have already done two revision, and I worked hard, and I would say I've increased from 41 mm, which was very restricted last time, right? Now that I can do to close to about 48 to 49. It's improving,
in your own case.
But it's in my own case. So my point is just that I did it 4 years ago, 5 years ago, right?
You did
so if you
lingual frenectomy.
Yes.
Okay.
Yeah, and I make effort. So the protocols are out. You can refer to Zagi's research, and I think it's very helpful to understand that we need to do physiotherapy in terms of myofunctional therapy before we do tongue tie release, and after that we have. So don't get too fixated about releasing the tongue. It is not the end all. It doesn't solve the problem, or just based on that alone, right? It comes from just understanding the patient, right? That the tongue needs to go back to the palate first. Whatever the case, when we are tie or not tie, right? Just treat it like a tennis player. He need to go back to center court. If he's not in the center court and he try to play the game, it's going to be a trouble, right? When the ball is too far front. So I have a patient who is stuttering, right? He can't. Yeah, but I asked him, okay, just put your tongue up, slow down, take a deep breath, then you start talking to me. He make a sentence. He doesn't have any problem. But when he try to rush it, he will, because he can't coordinate between his swallow, his breathing, and his speech, because his tongue is not in the center court. But once he get back to center court, he's in control, right? And he can get better and better, which is the case. So all I want to say is that trust your body, right? We don't have to over-engineer it too much, but we just need to give it a bit more time and give it a bit more space to work it out. So as long we can get our patient to realize that the first thing is not actually tongue up, because if the mouth is open, we don't have a suction in the mouth. We can't get the tongue to go and stay up there for extended period of time, day and night. So first we have to work on the lips. orbicularis oris must close. Create the suction, right? Then work on the tongue, right? Tongue goes up, then we work on the swallowing, right? Proper swallow without thrust. And then, of course, they are obviously breathing through the nose. So tongue up, lip close, breathe through the nose, and proper swallow. This is what I always advocate. And I say I highlighted it in one of my TEDx talk, 2017, and tongue up, lip close, breathe through the nose, my mantra. So if we can get that for our patient, we're starting. So be it a child, be it an elderly person, be it a strong athlete, no pain. As long he is not putting his tongue up, he's not at his maximum. So when he put his tongue up, yeah, we have better stability. So I even tested, like, for example, with our optimized bite or with tongue. Yeah, you realize some of them with the tongue up, they are very close to the optimized bite. So to me, optimized bite is very helpful to get my patient to the early stage of winning, okay? Because if I just ask them to train their tongue, some of them will drop out and get tired and yeah, I'm not seeing any results. So they lost faith. But if we can get the bite through a neuromuscular tense and the jaw, I can get this orthotic in immediately. Okay, click on patient bite. So now he has this neutral position, right? He is getting better from many of the symptoms, and he's getting a little bit more volume because most of them typically have more constricted jaw, deep bite, among other things, right? So even the tongue tie, for example, right? So, but thankfully, this device is on the lower jaw. If we put it on the upper jaw, we're going to create problem for this patient because we're going to occupy the space that the tongue's supposed to go to, right?
That is
So
really important point to talk about that, because combination of myofascial therapy and everything, but also with the device that we always try to explain why it's important to have it to the bottom. Great. So then, okay, sorry, go ahead.
Yeah. So for me, before I do expansion of the arches as well, even for adult patient. So I get them to, I don't extract any teeth, and I want them to get the teeth to come out to the whole right position. I tell them, I can't grow your jaw. I can't create the difference in your palate. I can't get your buccal corridor wider. Or should I say buccal plate wider? I depend on you to use the tongue, use it like a rolling pin. Every time when you breathe, when you swallow, when you rest, when you exercise, when you move, right? It's constantly activating the matrix of the jaw. And yes, true enough, for adult patient, we're seeing that whole growth and development. And then I can line the teeth out. So, and for young children, it's easier, even easier, right? They have growth potential. Adult, we have remodeling potential. But we can't do it. As dentists, we can't expand the jaw. I agree with all the theory out there. But when the patient wants to do it, the tongue can exert a 1.2 kg worth of force, right, against the palate. Our plate, I don't know, 100, 150. Aligners, Invisalign aligners are only 50 grams, right? So can you imagine if 50 grams can move teeth and really widen in some cases? What if this elephant in the China shop, right, decide to go to the right place and not go around and bounce around and create all the wrong positioning and function again? So get the tongue to be on our side, right? So my orthodontic treatment always start with the evaluation of myofunctional issues, right? We, even for adults, when they come in, I ask them about their breastfeeding, about whether they use bottle, do they remember they're on pacifier for how long, right? We trace that whole history from there and say, look, you have this problem, and they always tell, yeah, I have sinus issues since young. Of course, you breathe through your mouth since a child. So if we don't address and eradicate that problem right at the beginning, how are we going to get success now, treating, and how are we going to get long-term stability? We can't.
Correct.
Yeah. So we want that whole root cause to change first. So even for TMD issues, it's the same. For sleep issues, it's the same. So I don't want to create too many different protocols for different types of patients. We don't have to. And if we can go down to the root issues and we can just do that one thing right, we can actually effect many, many things that is ramification of this whole issue. So So for even, let's say, a TMD issues come in, pain, yes, we do our own evaluation, all that evaluation, malfunction evaluation, craniofacial pain evaluation. Then after that, we will, yes, take the bite. I will make an orthotic, right? The orthotic helps them to guide. And during the wear of the orthotic, I will also start myofunctional therapy, right? So then the patient is now learning how to put the tongue higher and away and to the top. So last time we're always talking about cutting some lingual spaces, but if the tongue is lifting up, we don't have to worry about lingual lingual spaces, because the tongue shouldn't be there fighting for that space at all. So if the tongue is up, then this help us to give the guidance. So a quick guide, the neuromuscular component knows, okay, I'm back home. I'm home. So this home then also create volume, create space, tongue train. There will get a time that you don't need this, and then we're ready for phase 2, orthodontics. Then now, right, I literally even sometimes don't even measure again. I take the orthotic, I cut a window at the side of the orthotic, then I can scan. So I relate the orthotic bite now, and I give it to my case. I use Invisalign. So with Invisalign, I tell them this is the relationship, and sometimes they will do some funny jumps of my. I say, I will write back again. Sorry, I've already established the AP, anterior posterior position. Don't change it, please. So all you need to do is do your level and a line, and sometimes you do a vertical jump for me. So that comes to a question about the VD, the freeway space. Again, I leave my patient to determine that over time, right? So I literally don't need a stabilization spleen when I go into phase 2, because the stabilization spleen is the tongue will stabilize it. The tongue will stabilize it for me, and the patient doesn't need to go into any bite, only when he's chewing. And anyway, orthodontic patient always go into funny bites all the time, because sometimes they have to jump the bite for the teeth, right? Or because of lateral cross bites or anterior cross bites. So, okay, so they are now finding their own position. Of course, like say, other helps will come in, right? It can be from a physical therapy, their own exercise program, and many other things, breathing techniques, right? All this is helpful. And then for me, I also utilizes laser or photobiomodulation. So using lasers, sometimes it helps me to really get some relaxation really fast. I have both the Epic laser, right, is a diode, wavelength 900 plus to actually help. Or I also use the Photona Lightwalker, and it has a Genova handpiece. So 1064, very helpful also in getting some of this area.
We're getting close to the 20-minute mark, and I'm afraid you've in your descriptions you have answered some of the questions in a less formal way. So I think what do you think, Javi? We should go to the questions at this point.
Yeah, we can jump to some of them. I have 2 questions that it relates in the way, so we don't let everything hanging. So it's a question is, besides the myofunctional therapy for training of the tongue, are you using any kind of appliances, mostly in kids? Like we're gonna have one speaker talking about orthopedics, and then in the orthopedics foundation, we utilize appliances most of the time, bimaxillary appliances, but with freedom, and we try to stimulate the muscles of the tongue. And then we create some proprioceptive into the papilla to the kid to start playing and develop and get into that. Are you combining any of these procedures in the cases that you're working, or just a strict myofunctional therapy exercise?
Yes, I do even use this kind of devices, or sometimes it's like say it's a stock, not customized tray even for my adult patient also. I combine it even with Invisalign, for example. When they wear the Invisalign, I will ask them to wear a Myo Munchie. So it's a soft silicone device that actually can change shape a little bit better when it comes to mal-aligned arches. So they go in there and they do chewing. So when they do chewing, I'm trying to coordinate the nerves. and coordinate. So what I want is, again, a patient has the own proprioception to actually raise the tongue. And yes, initially it's slower. If you put something up on the upper plate and try to expand with, screw forward, backwards, sideways, should I say, you will actually get a faster expansion. But again, I have to train the tongue again, right, after the appliance is removed. So why don't I just start right at the beginning? So at the early stage, it's a slow climb. But once my patients can get the tongue up, right, I'm getting a lot more velocity in terms of the growth and development change. So for younger patients, now we have even smaller devices that is meant to even switch them out of their pacifier. So a pacifier or the milk teeth will press the tongue down because it occupies the space on the top. So one of the studies from Professor Christian Gumino, preterm babies born early in the NICU, and then they have to be bottle fed, and 6 months into bottle feeding, they have normal palates and they become abnormal after 6 months. They have hypotonic tongue and they have sleep disorder breathing, right? Sleep-related breathing disorder after 6 months. So you can see the effect of a bottle teeth on the function of the tongue and all the physiology of the whole body, right? So we understand that to promote more upward movement of the tongue. So we exchange out a sucking device for non-nutritive kind of sucking, compensate with a chewing device that will actually help to then stimulate the cranial nerve. Yes, so I explained it
Kind of
earlier
like a
before.
Myomanchi.
Yes,
Mayo
yeah, even
Munch.
for a younger one, the Mayo Munchie baby. So we have that, and even there's a French product called Spoony Gloss. Okay, so it looks like a I'll send you that link later on the Spoony Gloss. So it actually insert right underneath the tongue.
Yeah, you can
Uh-huh.
put all this into the interview in notes. That can be good reference. Now, I
Yeah.
have another quick question before we jump to this. So then you're doing Invisalign as a big part of the alignment of the teeth, and you treating pretty much the patients to trajectory. So you start the patient with an orthotic, and then you start developing the arches base in that mandibular trajectory. Then you send the case for Invisalign treatment, and pretty much what you're doing is arch development. And then my question is, so are you closing the bite in trajectory, or you're also involving verticalization of the posterior segment and some level of intrusion into the front to try to compensate the vertical growth? How you handle that part?
Yes. So sometimes with especially very lingualized molars, I'll try my best to upright. And there are some reverse curve or speed that we need to actually level off as well. And there's some really obvious premolar drop off with the incisor over eruption in some cases. Yes, we also have to actually intrude those. And then
You go more for intrusion than verticalization with clear aligners.
yeah, the truth is, right, it has a lot of passive eruption in place. That's one thing. And the second one is sometimes we ask for extrusion. Well, what I do is that I get them to bite on the myomanchi so that the aligner sit well, so that it really grip the teeth well, and hopefully that translates properly for the cases. And I don't put attachment in most cases. Yeah, almost all now. And I'm just trying to just get this whole natural thing of chewing to sit, and then let the tongue give that space, the freeway space for the patient, so that the passive eruption can come back in. And then for the lower teeth, right, because the tongue is no longer sitting on them, so and the upward movement of the tongue, the inside of the floor of the mouth, right, it actually can help out as that. And then when the mouth is closed, the buccinator is not pushing. And when they swallow, again, also that it doesn't have all that no accessory muscle movement, right? All that is removed so that the tongue occupies back and start pushing from the inside out. And then the curtain of forces from the lips are then rebalancing to form the neutral arch zone, right? So then the actual figure of where the bite it will be is my patient will tell me. Rather, I determine it for him. So it makes it easier for
Right.
me to actually address the issue. And the truth is, once they get their natural system working, really it is more accurate than what we can measure most of the time. So I trust the body, I trust the system, I trust my patient, and if they trust me, well they get healthier. That's how it works. Yeah.
Awesome.
That's it.
Awesome. So now it's
I
time,
think-
Hamid.
All right, it's 15 minutes. We're gonna go like Olympic speed through this. What is
Occlusion.
occlusion to you?
Occlusion is, I say, is this very, very intricate balancing of all your cranial bones with your muscles, right? Adjusting to that right position that facilitate breathing. Yeah, that is survival. As long as you can get air, right? That in that balance form without causing pain, right? Of course, you also can facilitate breathing with pain. So in that very neutral position. So occlusion doesn't come with just teeth, but it's every single piece of bone, right? And the muscle interaction with the neurology involved.
Awesome.
Who were your influences, would you say?
You, Javier? Definitely, yes. You both of you taught me so much.
Thank you.
Thank you.
But
Uh,
very well.
yeah.
So I think question number 2 you have answered. What factors do you consider prior to stabilization? Just briefly tell us about the quietening of this neurovascular, neuromuscular system through your eyes.
Yeah, so and if patient already come in with pain, definitely we'll take a tense bite, measure with K7, address with an orthotic device, so that we have some time and also a chance to rehabilitate. And again, I have gone a little bit more shortcut, yes, to find that position. So instead of measuring all those EMGs, I do without that. I'm going for just a scan 4-5, really just quickly get the bite right. Then I train the tongue. So because once the tongue comes into play, it influences all the cranial nerves and all the rest to coordinate, right? Because it's important as well. So the readings is just going to go off anyway. So I'm just getting the patient's body to then tell us. And then once they get into a better position, is how better is because patients say less pain. But I have experienced patient overdoing it. That means I gave her orthotic and I told her about tongue exercises. She said, no, I know how to do it. And she just trying and then recruiting all her super hyoids and all this to just get the tongue up, because it's not about just getting the tongue up. It's the tongue getting up, not the rest of the things supporting the tongue to go.
Without compensation of all the other structures.
Exactly. So that they can actually create problems. So we want stabilization by in a very neutral sense, right? And patient can actually achieve it, and achieving again, like say lip seal tongue up, and then breathe through their nose with a proper swallow.
Fantastic.
So that's for me. Yeah.
Weng Cheu, the next question is that which type of or what diagnostic information do you collect before you start?
So typically, yes, we have our myofunctional form. So we trace quite a few things regarding, like their breathing technique, the breathing ways, right? The swallowing, and their postural component as well, and like say history of even feeding and all that to understand a myofunctional deficiency or not. And then from there, the truth is everybody has it. So we cannot don't diagnose that. So especially for those seeing children, if you allow a child to come in to just clean the teeth, patch a hole, and then let them out without addressing it. Even ADA, American Dental Association, with the help of Steve Cartenson, already started in 2018, starting airway education for all the dentists in US. Right, 2019 is even a more comprehensive program. The 11 statement of responsibility for dentists, right? One of them is for children, right? You're not only just to ensure dental health, but also optimal airway, right, and breathing pattern. So it is starting, right? World Dental Federation, or FDI, also sent out a signal in 2018. The Buenos Aires General Meeting, they have a policy statement asking more institutions, university and societies to actually train dentists to look into this so that they can support either by screening, doing MAD, or helping medical doctors to actually help this. So, and also Lancet also published 2019. 2019 is stated 1 billion patient is at risk for sleep disorder breathing. All right. And that is understatement. Now with COVID, I think there's even more patient that's going to have breathing disorder. And
Right.
the recent paper by Sleep Medicine, right, 2020 just came out, right, talk about how adenoid tonsillectomy, 60% to 70%, we have a recurrence of OSA. Short-term divergent result, long-term no benefit. CPAP will flatten the face, right, cause distortion and retrusion and all these kind of issues that with growth and development. So what is advised is adjunctive treatment, maxillary expansion, oral devices, and myofunctional therapy. And they now understand and recognize that in sleep medicine, we have to address not only the physical, but also the functional. So as dentists, we are poised. We are in the best position to do all this. If we let it go, we give a birth.
Give it a great
And
opportunity.
if we talk about this, yeah, and we're not only in charge of the trigeminal nerves, we're in charge of all the 12 cranial nerves at our fingertips to control, right? So if we are able to do that, we are also addressing many, like for example, cardiovascular diabetes, hypertension, obesity. Four of these big ones, right, are all related to airway. And who can expand and train the tongue better than anyone else? Us. And once we can actually put the tongue in, again, breathing retraining, breathing pattern is changed, optimization, light therapy on the mitochondria, really translating to ATP and all the wound healing, pain control, and all the optimization of the body. So as a dentist, we are so poised to actually control the flow of air into the nose, open up the space and volume, park the tongue correctly, open up the airway, readjust the whole head neck, align from the head to toe, right? And then we change our breathing technique, increase more carbon dioxide so we can have better, translation or release of oxygen from our red blood cells due to the Bohr effect. And then with the oxygen now inside our cells, we have the red light therapy to actually translate this into the ATP, the final product that we're looking for, right, to make us strong and powerful, to quantum physics. Actually, that's the other area that we have not explored yet in quantum mechanics in all this. So once we get into quantum biology and understand it properly, right, we will be a different kind of human being, and we'll be stronger on our own accord. And
so we can say that in combination with the other records and devices that another physician be using, like jaw trackers, tense unit, chewing cycles. The part that you put in here is two big elements. One is myofunctional therapy as default in all the cases to retrain the muscles, but also you're working with light therapy using cold lasers or low intensity lasers, what it's called, to try to stimulate the regeneration of the cells. So that's awesome. That's really, really big points into this conversation. So let's jump to the other question because we still are in time.
I think, we're on the
last 7 5.
Minutes.
Yeah, no?
Okay. So, 5, I think he's answered whether he does interdisciplinary approach or not. I think you've established that you work with chiropractors and DOs and all that, osteopaths. Question number 6 is that if you had to establish a sequence of treatment, what would be the order to analyze and treat to a desired VDO, which I think, again, partially of your vertical dimension, you have answered utilization of the tongue.
Yep. So, like I say, the tongue is proportional to our body, right? So your tongue and my tongue is different. And so your tongue will guide you a lot better in in terms of its dimension, its ability. Yeah, so as long as you get it into the right place and work it every single moment, right, it will serve you well, right?
Yeah, so this question has a modification that we have to talk honestly, because I think the pathology of the tongue will influence your vertical dimension in different ways. If you have a patient with lateral tongue thrust, definitely is going to inhibit the proper natural verticalization, what is going to create a lack of vertical dimension and unsupported bite. And I did think this is more dramatic, the change in vertical dimension. But let's talk about those patients that they have tongue thrust or protracted tongue into the front segment, that they have more the opposite effect. They're trying to develop open anterior bites, tendency open anterior bites. What it can be that in reference to vertical dimension, to you say, okay, I'm gonna work because the patient is creating me counterwise growing, let's say, how I gonna work that vertical dimension, or what can be your reference to establish what is gonna be the vertical dimension that we do gonna choose for that particular case?
Back to my same question, answer again, so I say I leave it to my patient. Of course, it's not like totally just leave it, but you see, because when I do Invisalign with it, I do some posterior intrusion, right? And then I do some extrusion on the front. And again, the tongue is moving up to the palate, and it's actually creating some form of forward and anterior growth of the or modeling. And also because of the tongue pushing down, right? Now, should I say it's pushing up so that it pushes the jaw down, opposite reaction force. So then it actually creates that rotation changes as well in the front, right? So then it can actually help to close the anterior. So in this way,
I'm sorry, if I get this right. So your initial thing is to make sure that the tongue, first of all, not only it is in the right place, but it can go in there. So it's your evaluation of the tongue and whether it's free to do that to start your myofunctional is the very first thing you do, because you deduct all these other things from that, and the whole movement of the upper arch, movement of the lower arch, all really revolve on the correct function of the tongue.
Yep, and the lips. So the thing is that, right, sometimes we can't get it to the full function because of, like you say, restriction, or sometimes no restriction, but it's just weakness. A very low tongue posture. Weak. Yeah, they have. It's just like I'm able to do a backflip, right? But I can't do it now until I train to engage some of my muscles at the back. So it's the same thing. Some of them have no reference of whatsoever where the tongue is in their mouth all their life. So now that you brought it to attention, they think about it, and then, yep. So next time they'll come back to you and say, yep, now I can't think anything else. I make sure my tongue is up against the roof of the mouth. So when they can do that, you know they are helping themselves and helping you to actually achieve the results that you want for them. Yep.
Fantastic. I'm going to skip the next one because you told us you don't do, the next question was whether you consider the facial aesthetics in your final treatment, and that's more has a restorative connotation. I know you told me that you don't do a lot of restorative work in your population is there, but from even in the younger population, do you look at the face and say, yeah, well, the lower third needs to be a little bit longer, or the mid face should be a little bit more forward? And, can you tell me that?
Yep. So I think, say once the tongue doesn't go up, right, we always have a maxillary deficiency. So it can be playing out in many ways, in terms of lateral, in terms of the, the dome, whether the arch comes down or not, right? It can also be then undergrowth anterior. It can be also, maxillary excess. So then when the upper is small, then your lower have to be like, okay, I have no space to fit, right? So either I go back a little or I go forward a little. So then you end up with your class 2, class 3. And sometimes even adenoid tonsils play a role. One of my mentor, also from Taiwan, Dr. Huang Qiqing, also highlight this, that for class 2 patients, typically adenoid issues. right? So they can't breathe through a nose, they use more mouth breathing. So then the tongue is low and they tend to have a class 2-ish kind of occlusion.
But that's,
And then if,
I'm sorry, but that is a chicken or egg question. How did the adenoids get big if the patient wasn't a mouth breather to begin with?
yep. So the thing is that, right, there is always like say, this whole Verda's belt behind is going to get enlarged somehow, right? The tonsils and the adenoids. So it's just that he observed, and it's also in one of the papers he highlighted that yes, it's just that you can correlate a little for the class 3-ish. So that's why they say why class 2 and anyway upper is small, right? That we agree, right? Upper is small, deficient. Then the lower, if it become a more class 3-ish, tend to be with the adenoids, or so I say the tonsils are huge. So they're swollen here, then the tongue always stay a little lower to allow for the airway to open. So they tend to have a more class 3-ish tendency. So again, if we are trying to address all these issues without addressing the tonsil adenoids, we have a problem. But to me, I'm typically not towards the surgical, but of course, there is also need for surgical. If not, the ENT or the physician should come in to help reduce down the inflammation. And we have other devices, like for example, photobiomodulation also reduces inflammation. Diet control reduces inflammation. So all that can be put into place so that we can get the shrinkage. I have one 3-year-old, 3.5-year-old. Yes, the mom put him through all this malfunctional strict diet, photobiomodulation, and the tonsil shrunk. So I've seen it, and I would say we just need a little bit more patience and also faith in the body to actually revert back to normal.
And more data.
And more data. Yes, definitely research. We need more research.
Fantastic. Awesome. Next question, really quick. I know you're not doing a lot of surgeries, but Javier really wants to have this included. In terms of regeneration of the condyles, have you seen, heard, or know anything about the introduction of growth factors into the jaw joint in order to facilitate regeneration?
I understand that we can actually do that, but again, I say if we do that, again we have to take a lot of things either out, process, and in again, right? So why don't you think about photobiomodulation again, right? Without having to address this in and out. So we activate the mitochondria, right, and allow for the transcription to actually address that whole inflammation and regeneration. And if you want more stem cells, you can even just go to your tibia bone or go to your sternum, right? You can actually apply light here and also on your tibia, and you can actually create more stem cells for regeneration. Don't have to even take anything out from the body. So there is other ways as well, and this is something that I utilize.
Yeah, definitely. Cold laser has been, and light therapy is really big in Europe. America, we just we not adopted too much. It was a Dr. Lido, who developed some of the cold lasers here in the States, and actually was not as popular. And at some point, Steve Olmos was using cold laser, that is another type of phototherapy, to stimulate. But the concept, America is run by a lot of political issues, unfortunately, and then that went through. But now I've seen more companies doing photostimulation. Safad is an amazing unit made by Biotech in France, that there is a full camera and is programmed by a computer. So it depends on what you want to achieve to make the programmation. Really amazing thing for you, mostly that you're in this arena of photo stimulation. Okay, Hamid, what is the next question?
Question number 9 is, do you notice, I think we have answered, do you notice any postural changes after your treatment, expected or unexpected, positive or negative?
So one of my teacher on posture is my patient. He came in with a neck like this, right? And yes, he has a tongue tie. And after we do the rehabilitation, we release, tongue is up, and he is straightened up in 3 months. He speaks clearer, and all that. So well, the body is compensating. Again, like I say, we just need to stay alive every moment, airway, right? So the body will do funny things just to keep you alive. So once we put it back into a more normalized position, yep, it's going to be all right again. It's expected. Yeah, posture should change.
Now, this next question, Weng Cheu, is more of a philosophical one, and I want to ask you: do you think that at any point the field will be open to more of this type of holistic or organic approaches to occlusion?
Yes. And
Meaning in education in universities.
it has to be. It has to be. Like for example, now I'm actually working with our university system engineering department. So we went all the way to the system engineers because we want to employ system thinking and computational modeling to help us to put all this together and relate the interconnectivity of the body so that we can understand it a little bit better through the algorithms. And not just, I think the conventional way, we have a lot of data. We have a lot of research that's already looking into so many components of the body, but we're not putting them and linking them together enough, right? So that's my life work now is, like say, I told Professor Andrew Lim that this is going to be that something that I will have to and create something that will help individual, medical, dental, right, layperson involved as well to understand the body in the most dramatic way. Just like predicting weather, so you can put in a parameter here, and you can actually see the differences over there, and it should be able to be computed. Yep.
Oh, sounds great. Last question, and this is another blank or blanket type of question. Thinking about the joint itself, okay, what do you think there are the sequence of events as it happens as when we open? We're talking about rotation versus translation, and you know, optimally when you finish your case, this is like different parts to it. Where do you foresee positioning the head of the condyle? What is the ideal position in your mind? And what type of occlusion scheme are you expecting?
Okay, like for my case, you see when I open my mouth, I have a click. Okay, if I open like this, yeah, I click because I have a tooth that actually deviated my whole jaw for many years. If I put my tongue up and open, the trajectory is clean, right? Of course, we don't have to we won't open with the mouth, but as long the tongue is like your, you know, your spaceship that goes docking back into the International Space Station properly at one spot. You can't dock it any other way. Every time when you start from there and end with there, start from there, end with there. So it gives you a very clean trajectory start end point, right? This will help the joint to establish a functional position well, right?
Yeah,
And
but
again,
what
it's
happened first? That what we're trying to hear is because, as a fact, we're trying to standardize some information because we're making a statistic tabulation through the students of the Prostorante program at the University de Augusta, the Georgia College of Dentistry. And we try to make a consensus of all these questions to be able to make some data tabulation and see some statistics about the thinking process about all of you guys. So we want to know, like, you consider that it's going to be a translation first or a rotation. We're trying to clarify many dogmas that is in the literature that you say that you have first a rotation, 2-3 millimeters, and then a translation. And then I personally show studies that I have that it shows that most likely translate is many articles also that support the fact, like Mapelli, that he's talking and he make advanced studies and demonstrate that translation was at the same time of first that rotation. that is for a connotation standpoint. So based on that experience, when you do that, what do you think, which events happens first, or you think it's combination, or you just let us think about it, but
Yeah.
what we want to create is an opinion different than a dogma.
I think it's, yeah, because you see, the starting point has to be a right reference also. So like, for example, if I have a lateral shift, right? Mhm. So this is, my condyle is like this, okay? So when I open, I will expect that this will translate, then it will rotate more, right?
Yeah. But let's say
Yeah.
in a normal range of motion, what do you think that happened? Understanding that we're talking about the condyle position, know what really
Okay.
happens into the compartments, in the lower
I
compartment of
don't think
person.
the research is out yet. So maybe, yeah, please help me out. So to me, start with the tongue up, lip closed,
Mhm.
and then start opening. Yeah. Then
Okay.
you talk about your cine MRI. So if you have all that able to capture and then close up, I think you will have a better idea with the tongue in reference, right?
Mhm.
Then you see where the how the body reacts. Yeah, nobody has done that before. So I think I encourage you to do that and share it with us. Yeah.
Definitely, I will. That's an interesting topic. Jaw motion with tongue in the top, but what we want to see is the seating of the condyle. What happened right there? But thank you
Yeah.
so much. Now, do you ever take X-rays of the condyle position when you take your CBCTs when you finish your cases? Do you get to see like any particular position that you found that is a consistent pattern
Yeah.
when you take your part?
Yeah, I'm quite conservative with the radiation for the end stage. So until the patient is really like I need to prove something that I don't usually take a finishing. But the pre is because it's a medical document that I have to preserve. Yeah, so usually I start off with a CBCT or sometimes joint X-rays or lateral ceph. But when I end, right, in some cases I do some radiograph, but most I would say, yeah, I leave it. And especially my population group is younger, so I tend not to take too many X-rays for them at the moment.
Okay, great. Now, final question is, so now we're talking about that final stage where the teeth met together, that we know now that that is more called than just occlusion, you know, it's
Yes.
just the relationship between the teeth. How is your relation into your teeth when you plan in your case because you do more ortho? Are you looking for more cost-fossa relationship, cost, interdental space, or how is that transition in these patients with some skeletal discrepancies? How you will try to play the occlusal scheme in contacts just to create a stability of the rest of the system, because that's definitely occlusion helps to keep also the stability of the system.
Yep. Yep. So thankfully, again, also in the clean check of Invisalign, we can see some occlusal contacts when we land the cases. So I agree also with Peter that a lot of um, you know palatal tube on the upper to actually close, which is not ideal. I want to create more vertical alignment on the upper so that there's really a freedom of entry and exit sideways, and also for the anterior, yes, there's some guidance for the anterior T. But the truth is, right, one prosthodontist also gave me a thinking process also. It's like, if you look at all our ancient skulls, right, we have been eating and chewing and we have flattened all our teeth. Yeah, and we have been functioning, right? So the cuspal relationship is important at the moment when we start to chew, right? Um, but if let's say the tongue give you that substantial amount of stabilization, you might not need to depend a lot more on this clench, right? So the cusp tip to T contacts are very functional, very limited, in my opinion, to the chewing. It also give us, of course, the proprioception. If it's too far off, of course, we're going to still get disorientated. But once it's in the neutral, then I feel it doesn't play that important a role. As long as within the neutral zone, right? I think we are in good function.
So if I hear you right, in your setups, you do try to recreate curve of Wilson and curve of Spee, and you try to get the posterior teeth to intercusp properly, like
You
a
have
cusp
to,
to fossa relationship.
because we are not dealing with flattened teeth. The truth is, right?
The younger
We're
population.
dealing with, so we still need to respect those interaction between the cast tips. But it's just that I'm just saying that there is something beyond it to actually guide. And if we take that into consideration, you see, even if I land it correctly, let's say, and the tongue and the lip buccinator function is wrong, it's going to recreate a wrong relationship also, right?
True.
So that's why if I get the right function to come in, I might not even finish the case when I finish it. Okay, or should I say I don't finish the case when I complete it. The patient is continuing that finishing. And one of the result is shown by Professor Isuko Kondo. Kondo Sensei is Japanese orthodontist, right? She showed a 40-year follow-up on one case. Amazing tracking of this gentleman, the young boy, 9-year-old until he's 50. So you can see how well the whole facial profile continues to grow, you know, the stabilization on the neck, and the teeth is still in good position. And the wisdom tooth erupted a bit curved in when he was 22. When he was 50, that tooth is uprighted, right? So what I'm just saying is that the function component will beautify all this over time, right? And if the function is right, the form will be right. Yep.
Awesome. I think it was worth it to go over time with you. Thank you so much. Has been really
a pattern.
My God, this is honestly, I'm feeling like selfie because I have all the questions I want, and that is beautiful. And I want to be able to interpret the questions of another people. We don't have many questions here. I just have only one question. I don't know how many you have some questions from people out there.
I don't have a lot, no.
The only one that I can see here, but by the way, I want to clarify to all the people, all the audience, we collecting all these questions that you guys have because not everybody has the opportunity to see the lectures live because they're different in time, because we have people all over the world follow the concept of let's talk about occlusion. So many questions that they proposed there, we didn't have the chance to answer them. So just to let them people know that you can feel free to send us the question, to put it. We have somebody working in reviewing which questions we add in, and we're gonna get answers to that. Remember that we're gonna have a rapid session when we're gonna go over question about to summarize everything about how these amazing speakers has been thinking in physiology and in occlusion for a really, really different perspectives and how we feed ourselves now. And I think we go like we're not talking about COVID, we're not talking about what is happening. I think we're doing our job, that is feeling to be prepared to when this is gone, we know what we need to reinforce, because the difference in treatment is going to be which services we're going to offer to the patients, and that go beside aesthetics. We're going to be more in this holistic approach that we have. So one more time, thank you so much, Yuen. This is amazing. I personally need to connect my chip with you more to learn more about you because you're fascinating. And we didn't even talk about the vagus nerve in sense.
I know.
So imagine.